Welcome to Section 2. In this section, I will be discussing the equations that are relevant to the renal system. The focus will be explaining them both conceptually and mathematically using many examples. Let's get started. This section is divided into 4 parts: clearance, flow, filtration, and acid-base. I will discuss clearance first and then move on to the other parts. So clearance can be determined with the equation C equals UV over P, where C is clearance, U is urine concentration, V is urine volume over time, which is also called urine flow rate, and P is plasma concentration. On the side here you can see the units that each of these is measured in. Conceptually, clearance refers to how much of a substance can be removed from a certain amount of plasma volume per unit time. For example, the normal clearance of creatinine is 100 milliliters per minute. This means that the kidneys remove all of the creatinine in 100 milliliters of blood in 1 minute. Okay, let's do an example. Let's say there's a patient with a plasma glucose concentration of 1 milligram per milliliter, a urine glucose concentration of 0.01 milligram per liter, and finally a flow rate of 1.5 milliliters per minute. So in this patient, what would be the clearance of glucose? Okay, plugging these numbers in, we get 0.01 times 1.5 over 1, which equals 0.015 milliliters per minute. And this makes sense. It makes sense that the clearance would be low. Normally the kidneys are really good at reabsorbing glucose and keeping it in the plasma rather than losing it in the urine. So we'd expect a low concentration in the urine and a high concentration in the plasma. Ultimately, this translates into a low clearance of glucose. In fact, this number would be unlikely in a healthy individual because there shouldn't be any glucose loss in the urine. Okay, moving on to flow. When I say flow, I'm referring to how much blood or plasma reaches the kidneys. Renal plasma flow, or RPF, specifically refers to the volume of plasma that flows through the afferent and efferent arterioles in a given amount of time. RPF can be determined using the equation renal plasma flow equals mean arterial pressure divided by renal vascular resistance. Renal plasma flow is measured in milliliters per minute. Mean arterial pressure is measured in millimeters of mercury. And renal vascular resistance is measured in milliliters of mercury over milliliters per minute. As you recall from the section on cardiology, mean arterial pressure equals cardiac output times total peripheral resistance. Remember, there are several types of resistance that show up on exams, so it's important to be familiar with each of them. Total peripheral resistance, or TPR, is the resistance in the systemic circulation. Sometimes this is also referred to as systemic vascular resistance, or SVR. Resistance from the pulmonary circulation is referred to as pulmonary vascular resistance, or PVR. Also recall that one of the major contributors to resistance is the radius of the vessel. As the vessel constricts, the resistance increases, and as the vessel dilates, the resistance decreases. Okay, so this makes sense. If the cardiac output, or the amount of blood leaving the heart, is increased, then the mean arterial pressure will also increase. We know from this equation that mean arterial pressure is proportional to renal plasma flow. So that must mean that renal plasma flow must also increase. Likewise, if the total peripheral resistance decreases, then the mean arterial pressure would decrease as well. This would translate into a decreased renal plasma flow. This makes sense. For example, if a patient is in anaphylactic shock and the vessels are massively dilated, then plasma is moving from the circulation into the interstitium, which ultimately means less plasma is reaching the kidneys. So you can see that the heart must be pumping blood and the vasculature must be intact in order for the plasma to reach the kidneys. Okay, moving on to renal vascular resistance. This is essentially the same idea as pulmonary vascular resistance in the sense that we are focusing on one organ system. We're talking about the resistance, but only the resistance generated from the kidneys. In other words, we're talking about the resistance generated from the afferent and efferent arterioles. As you recall from the previous section, the afferent arteriole contains blood that enters the glomerulus, and the efferent arteriole contains blood leaving the glomerulus. If the afferent or efferent arterioles get smaller, then the resistance goes up. As we can see from this equation, if the renal vascular resistance increases, then renal plasma flow will decrease. In other words, renal plasma flow is a function of cardiac output, the integrity of the vasculature, and the patency of the afferent and efferent arterioles. Okay, renal plasma flow can also be determined using another equation, which is RPF equals the clearance of para-aminohippuric acid, or PAH. As we just discussed, clearance equals the urine concentration times the flow rate divided by the plasma concentration, or UV over P. So with this in mind, we can say that the clearance of PAH equals the urine concentration of PAH times the flow rate divided by the plasma concentration of PAH. Remember, PAH is freely filtered, actively secreted, and not reabsorbed. Let me draw this out to show you what I'm talking about. Here's the afferent arteriole, the glomerulus, the efferent arteriole, and the remaining portions of the nephron. The efferent arteriole continues on to provide blood to the other regions of the nephron, such as the proximal convoluted tubule, as I've shown here. It is here that the remaining PAH is actively removed from the blood and secreted into the nephron. So again, PAH comes in from the afferent arteriole. It's filtered. Some of it goes to the efferent arteriole, and the remaining PAH is actively secreted into the lumen of the proximal convoluted tubule. In other words, nearly 100% of the pH that reaches the kidneys is either filtered or secreted and then lost in the urine, which is why the clearance of PAH is a good marker for renal plasma flow. Let's do an example. How does the concentration of PAH change as it is filtered and passes through the nephron? The concentration is relatively low in the plasma, and this is because it's freely filtered. It's also relatively low in Bowman space, but quickly becomes more concentrated in the proximal convoluted tubule, and this is because the majority of pH is secreted into the PCT. Now I'd like to discuss renal blood flow, or RBF. RBF can be determined using the equation renal blood flow equals renal plasma flow over 1 minus hematocrit. As you can see from the equation, renal blood flow is very similar to renal plasma flow. However, renal blood flow is different from renal plasma flow because it takes into account the red blood cells. Recall that plasma is what remains after the cells have been removed. So when you hear renal plasma flow, you should think of the portion of blood that excludes the red blood cells, and when you hear renal blood flow, you should think of the plasma plus the blood. So RBF is the volume of blood that flows through the afferent and efferent arterioles in a given amount of time. Okay, let's plug in some numbers to make sense of this. So RBF equals renal plasma flow over 1 minus hematocrit. Remember, hematocrit is the ratio of volume of red blood cells to the total volume of blood. So if 90% of the total volume of blood is comprised of red blood cells, then the hematocrit would be 0.9. Okay, here's an example. If renal plasma flow is 10 milliliters per minute, and the hematocrit is 0.5, what is the renal blood flow? Plugging these numbers in, we get 10 over 1 minus 0.5, or 10 over 1/2, which equals 20. Now let's say the patient has polycythemia vera. Remember, this is just a disease where the body produces too many red blood cells. So instead of having a hematocrit of 0.5, we now have a hematocrit of 0.7. Plugging these numbers in, we get 10 over 1 minus 0.7, or 10 over 0.3, which equals 33.3. So as you can see from these two examples, if the hematocrit increases, then renal blood flow increases. Hopefully now this equation makes sense both conceptually and mathematically. Now let's use the same equation. Renal blood flow equals renal plasma flow over 1 minus hematocrit, but rearrange it to solve for renal plasma flow. So if we multiply both sides by 1 minus hematocrit, we get renal plasma flow equals renal blood flow times 1 minus hematocrit. Let's do the same examples and see what happens to renal plasma flow. So what is the renal plasma flow if the RBF is, again, 10 milliliters per minute, and the hematocrit is 0.5? Plugging these numbers in, we get 10 times 1 minus 0.5, or 10 times 1/2, which equals 5. What is the renal plasma flow if RBF is, again, 10 milliliters per minute, and the hematocrit is 0.7? Plugging these numbers in, we get 10 times 1 minus 0.7, or 10 times 0.3, which equals 3. As we can see, renal plasma flow actually decreases in patients with polycythemia vera, or patients who have an increased hematocrit, because there's less plasma that reaches the kidneys and instead more blood that reaches the kidneys. Okay, let's do an example. Let's say the urine concentration of PAH is 110 milligrams per milliliter. The urine flow rate is 1.5 milliliters per minute. The plasma concentration of PAH is 0.4 milligrams per milliliter, and the hematocrit is 48%. So what is the renal blood flow? For this problem, we need to use both of the equations I just discussed. Renal blood flow equals renal plasma flow divided by 1 minus hematocrit, and clearance equals the urine concentration times the flow rate over the plasma concentration. We also need to remember that the clearance of PAH approximates renal plasma flow. Once we determine the clearance of PAH, we can plug this number in, which represents the clearance of PAH, into the equation renal blood flow equals renal plasma flow over 1 minus hematocrit, and solve for renal blood flow. Plugging these numbers in to solve for the clearance of PAH, we get 110 times 1.5 over 0.4, which equals 412.5. Now we can plug this into our other equation, which is 412.5 over 1 minus 0.48. And this gives us 793.3 milliliters per minute. In other words, 793 milliliters of blood pass through the afferent and efferent arterioles every minute. Moving on to filtration, the first equation is glomerular filtration rate, or GFR. GFR is the flow rate of fluid that is filtered from the glomerulus into Bowman's space. GFR can actually be determined using the clearance of inulin or the clearance of creatinine. Recall that clearance is calculated using the equation UV over P. So if we plug in inulin or creatinine into the clearance equation, then we can solve for GFR, as I've shown here. Remember, inulin is freely filtered by the glomerulus, but none of it is reabsorbed or secreted. And this makes inulin the most accurate measurement of GFR. The clearance of creatinine can also be used to measure GFR, but it's less accurate than inulin. However, despite being less accurate, creatinine is actually more commonly used because it's an endogenous molecule and can be measured more easily than inulin. Recall that creatinine is actually a byproduct of muscle metabolism, and it's produced at a relatively constant rate. The creatinine leaves the muscle, enters the blood, and travels to the kidneys, where it's filtered by the glomerulus. It's less accurate than inulin because a small portion of creatinine is secreted into the lumen of the nephron, whereas none of inulin is secreted. This means creatinine actually slightly overestimates GFR. It's important to note that the concentrations of creatinine in the blood are used clinically as a surrogate for kidney function, which makes sense. If the kidneys aren't working properly, then the glomerulus won't be filtering at full capacity, so less creatinine is being filtered and more creatinine is accumulating in the blood. Okay, let's go through an example. If the clearance of creatinine is 100 milliliters per minute, the concentration of inulin in the urine is 50 milligrams per milliliter, and the concentration of inulin in the plasma is 1 milligram per milliliter. What is the urinary flow rate? Remember that GFR equals UV over P. The clearance of creatinine was given to us, and we know that this is a good estimate of GFR. So we can conclude that GFR is 100 milliliters per minute. We also know the variables U and P, so we can rearrange the equation like this. To solve for the urinary flow rate. Plugging these numbers in, we get 100 times 1 over 50, which equals 2 milliliters per minute. Okay, let's do another example. Let's say GFR is measured to be 85 milliliters per minute using inulin clearance, but 100 milliliters per minute using the clearance of a newly discovered drug. What could explain why the GFR is higher when using the clearance of the new drug? Let's draw this out. Here is the afferent arteriole, glomerulus, the efferent arteriole, and the remaining portions of the nephron. I've just said that the clearance of inulin is 85 milliliters per minute. Let's imagine that 100 milliliters of inulin is circulating in the blood and reaches the kidneys. This means 85 milliliters is moving from the glomerulus into the nephron. This is then excreted and lost in the urine. For this example, let's assume that the remaining 15 milliliters can't be filtered because the glomerulus has reached its maximum capacity. In this case, the remaining 15 milliliters would move from the glomerulus to the efferent arteriole. Remember, inulin isn't secreted or reabsorbed, so none of the remaining 15 milliliters would be secreted into the lumen of the nephron. Now we have another compound that has a clearance of 100 milliliters per minute. We know that the glomerulus can only filter 85 milliliters per minute. Because that's the clearance of inulin, so we can assume that it should only filter 85 milliliters per minute of the new drug as well. So again, 100 milliliters of the new drug enters the kidneys, 85 milliliters is filtered. So what happens is 15 milliliters of that drug continues to flow to the efferent arteriole, and then eventually it gets secreted into the nephron. In the end, 100 milliliters of the new drug is detected in the urine, whereas only 85 milliliters of inulin is detected in the urine. The 100 milliliters of the new drug that's detected in the urine is due to maximum filtration plus secretion of the drug into the lumen of the nephron. Remember, this is actually how the kidneys handle para-aminohippuric acid, or PAH. It's freely filtered, actively secreted, and not reabsorbed. Another way to look at GFR is with the Starling equation, as I've shown here. Kf is the filtration coefficient. This number is intrinsic to the glomerulus and is a function of the anatomy of each individual. This stands for hydrostatic pressure within the glomerular capillaries. This stands for hydrostatic pressure within Bowman's space. This stands for the oncotic pressure within the glomerular capillaries. And this stands for the oncotic pressure within Bowman's space. When we use the Starling equation, we're looking at net filtration pressure, measured in milliliters of mercury, rather than milliliters per minute. I'll draw this out on the next slide to help you understand this idea conceptually. So this is the afferent arteriole. This is the efferent arteriole. Here are the glomerular capillaries. And this is Bowman's space. Hydrostatic pressure is just the pressure exerted by a fluid. As the volume within a space increases, there is increased hydrostatic pressure. Oncotic pressure is similar to osmotic pressure. It's actually a form of osmotic pressure exerted by proteins like albumin that pull water toward the direction of the proteins. So I'll write P for hydrostatic pressure, and pi for osmotic pressure. Again, there are osmotic and hydrostatic forces in the glomerular capillaries and Bowman's space, as I've drawn here. Normally the hydrostatic pressure in the glomerular capillaries is large and causes fluid to move from the glomerular capillaries to Bowman's space. Also, there are many proteins in the blood, like albumin, which tend to pull water from Bowman's space back into the glomerular capillaries. The hydrostatic forces in the glomerular capillaries are generally greater than the oncotic forces, such that there is a net filtration of fluid from the glomerular capillaries to Bowman's space. There is also a hydrostatic force in Bowman's space that causes fluid to move from Bowman's space back into the glomerular capillaries. Recall that proteins are normally not filtered by the glomerulus, so the osmotic force in Bowman's space is generally negligible. If proteins were there, however, it would pull water towards the direction of Bowman's space. Overall, there is normally a net filtration of fluid from the capillaries to Bowman's space. Can you think of a disease that would cause the oncotic pressure in Bowman's space to increase? Nephrotic or nephritic syndromes. These are diseases where the kidneys abnormally filter protein through the glomerulus. So how do you think the GFR would be affected in a patient with one of these syndromes? Well, if there's an increase in the oncotic pressure in Bowman's space, then this will tend to pull water with it, resulting in an increased GFR. Also note that because protein is being lost, that the oncotic forces in the glomerular capillaries decreases. So you can see that there is a decreased force here and an increased force here, resulting in an overall increased GFR. How would GFR be affected in a patient with severe benign prostatic hyperplasia, or BPH? In BPH, the prostate becomes so large that it obstructs the flow of urine. Urine begins to get backed up in the bladder, ureters, and ultimately Bowman's space. This results in increased hydrostatic forces in Bowman's space and results in a decreased GFR. Let's talk about a few more examples. Let's take, for example, atrial natriuretic peptide, or ANP. how would AMP affect GFR? Remember, AMP is hormone released from the heart. And this is in response to increased blood volume. This is the afferent arteriole, the efferent arteriole, glomerulus, the remaining portions of the nephron. This hormone travels to the kidneys where it dilates the afferent arteriole, which increases GFR. This makes sense. Anytime the afferent arteriole is dilated, more blood is able to reach the glomerulus, which means the glomerulus experiences increased hydrostatic forces and results in an increased rate of filtration. Ultimately, the increased GFR allows more sodium to be filtered and excreted in the urine. Water follows the sodium, and the patient's blood volume begins to return to normal. ANP also limits the release of renin to decrease blood pressure, but the mechanism here is not very well understood. Here's another example. What would happen to GFR in a patient with polycythemia vera? Like I mentioned earlier, polycythemia vera results in increased hematocrit, which results in decreased renal plasma flow, or RPF. This is because more red blood cells occupy the volume of circulating blood, so the plasma volume must decrease. If the plasma volume decreases, then there is a decrease in the volume of fluid that can be filtered through the glomerulus, so GFR must decrease. Remember, red blood cells are too large to be filtered, so renal plasma flow rather than renal blood flow is a good predictor of GFR. Okay, how would diabetes affect GFR? Glucose is actually a chemically reactive molecule. If blood glucose levels get too high, glucose can begin to react with the efferent arterioles, which is called glycosylation of the efferent arteriole. This is the afferent arteriole, the glomerulus, the efferent arteriole, and the remaining portions of the nephron. As a result of diabetes, the radius of the efferent arteriole decreases, which limits the volume of blood that can leave the glomerulus. This means the hydrostatic pressure in the glomerulus increases, which causes an increased GFR. Going along with this example, what drugs are useful in decreasing GFR and can be helpful in treating diabetics? ACE inhibitors and angiotensin receptor blockers, or ARBs. Both of these work to limit the effects of angiotensin II. Recall that angiotensin II normally constricts the efferent arteriole, so blocking angiotensin II with these drugs would cause dilation of the efferent arteriole, resulting in a decreased GFR. Okay, how does age affect GFR? Recall that as you get older, the nephrons diminish in number, which results in a decreased GFR. And in this example, it's important to note that elderly patients typically have a decrease in muscle mass, so the creatinine actually remains constant despite a decrease in GFR. Okay, here's another example. How would congestive heart failure affect GFR? Congestive heart failure results in decreased cardiac output, which means the kidneys are receiving less blood. Fluid also accumulates in the venous system because the heart is unable to adequately pump blood, and this venous congestion is experienced in the renal venules. The increased resistance results in decreased blood flow to the kidneys. So both of these forces, the decreased cardiac output and the increased resistance, decrease the blood in the glomerulus, which means there is a decreased hydrostatic force in the glomerular capillaries, which results in a decreased GFR. Finally, let's end this topic with a calculation. What would the net filtration pressure be in a patient with a glomerular capillary hydrostatic pressure of 38 millimeters of mercury, a glomerular capillary oncotic pressure of 25, millimeters of mercury, a hydrostatic pressure in Bowman's space of 11 millimeters of mercury, and an oncotic pressure in Bowman's space of 3 milliliters of mercury. Remember our Starling equation from before? If the Kf was not given to us, we can just assume it's constant and ignore it in the calculation. So if we plug these numbers in, we get 38 minus 11 and 25 minus 3, or 27 minus 22, which equals 5. Again, if you understand this conceptually, it's a lot easier to plug the numbers in. Okay, moving on to filtration fraction, or FF. Filtration fraction is glomerular filtration rate divided by renal plasma flow. Conceptually, filtration fraction is the percentage of plasma that's filtered through the glomerulus compared to the total plasma that reaches the kidneys. Let's do an example. What would happen to filtration fraction if the efferent arteriole is constricted? So this is the afferent arteriole, the efferent arteriole, glomerulus, and the rest of the nephron. Remember, anytime the efferent or afferent arterioles are constricted, the resistance in the kidneys go up and the renal plasma flow decreases. So if the efferent arteriole is constricted, fluid builds up in the glomerular capillaries, which increases hydrostatic forces, and GFR increases. So as you can see, GFR increases and renal plasma flow decreases as a result of constricting the efferent arteriole. From this equation, we can deduce that filtration fraction must increase. Here's another question. What would an increased filtration fraction tell us about glomerular oncotic pressure? If filtration fraction is increased, we can deduce that GFR is increased relative to renal plasma flow. This means more fluid is being filtered, and as a result, more protein is being left behind in the glomerular capillaries. An increased concentration of protein means there is an increased oncotic pressure in the glomerular capillaries. The next equation is used to calculate filtered load. Filtered load equals glomerular filtration rate times the plasma concentration. Filtered load is also sometimes referred to as filtration rate, which can be confusing because it sounds very similar to glomerular filtration rate. Filtered load is different from GFR because it measures the mass of a substance that is filtered per unit time, whereas GFR measures the volume of a substance filtered per unit time. This makes sense. If the plasma concentration of a substance increases, then more of it will be present in the glomerular capillaries, so more of it will be filtered. Likewise, if the afferent or efferent arterioles are dilated, or the efferent arteriole is selectively constricted, then more blood reaches the glomerular capillaries and increases GFR, which increases filtered load. Excretion rate is filtered load minus reabsorption rate. Let me draw this out to make it clear. Again, here are the afferent and the efferent arterioles. This is the glomerulus and Bowman's space, the remaining portions of the nephron. Substances moving from the glomerular capillaries to Bowman's space is called filtered load, or filtration. The amount that is taken from the lumen of the nephron back into the blood is called reabsorption. The amount that is moved from the blood into the lumen of the nephron is called secretion. It's important to note that reabsorption and secretion are collectively referred to as the net reabsorption rate, or simply reabsorption rate. I'll talk about this more on the next slide. Finally, the amount that is ultimately lost in the form of urine is called excretion. So you can see that the excretion rate is simply the amount of substance that is filtered after accounting for the amount that was secreted and reabsorbed. Okay, let's do an example. If the inulin clearance of a substance is 90 milliliters per minute, the plasma concentration of the substance, we'll just say it's substance X, is 1 milligram per milliliter, and the net reabsorption rate of the substance is 10 milligrams per minute. What is the excretion rate of the substance? Remember, filtered load equals the glomerular filtration rate times the plasma concentration. Also remember that the clearance of inulin equals the GFR. So we can plug in the 90 milliliters per minute as the GFR and 1 milligram per milliliter as the plasma concentration to solve for filtered load. This would be 90 times 1, which is 90. Now we also need to recall that the excretion rate equals the filtered load minus the net reabsorption rate. Using this equation, we can plug in filtered load as 90, and we were given the net reabsorption rate, which is 10, so we can plug these in and we get 90 minus 10, or 80 milligrams per minute. So the excretion rate of substance X is 80 milligrams per minute. If we rearrange the previous equation, we can derive reabsorption rate equals the filtered load minus the excretion rate. Again, here's the afferent and the efferent arterioles. This is the glomerulus, this is Bowman's space, and the remaining portions of the nephron. This represents filtered load, this is reabsorption, this is secretion, and this is excretion. Reabsorption rate is calculated by measuring the filtered load and then simply accounting for what is lost in the urine. If the filtered load is greater than the excretion rate, then the reabsorption rate is positive, and there is a net reabsorption of the substance. If the filtered load is less than the excretion rate, then the reabsorption rate would be a negative value, and there is a net secretion of the substance. Let's do an example on the next slide. If a patient is excreting 600 milligrams per minute of a substance, so the excretion rate is 600, and filtering 1,000 milligrams per minute of the substance, so the filtered load is 1,000, what is the net reabsorption rate of the substance? So what is the reabsorption rate? Again, reabsorption rate is simply the filtered load minus the excretion rate. We simply take 1,000 and subtract 600, which equals a positive value of 400. This means that there is a net reabsorption of the substance because the value is positive. Let's quickly draw out a nephron to show what's happening. So the afferent arteriole, the efferent arteriole, glomerulus, Bowman's space, and the remaining portions of the nephron. So we have 1,000 milligrams of substance that is being filtered. 600 milligrams of the substance is being excreted. So the question is asking about the net reabsorption rate, which is the reabsorption and the secretion. So this is the net reabsorption rate. If we take 1,000 minus 600, we can deduce how much of the substance is being reabsorbed. Again, because it's a positive value of 400, we know that the net reabsorption rate is moving this way, and it's a value of 400. Okay, let's do another question. A new drug has been discovered, which we'll call drug X. The drug is freely filtered and actively secreted in the proximal convoluted tubule. We also know that the secretion that occurs is a transport-mediated process. So knowing all of this, how would the excretion rate of drug X change as the plasma concentration of drug X increases? Let's draw this out. Here is the afferent and the efferent arterioles. It's the glomerulus, Bowman space, and the remaining portions of the nephron. The drug I just described behaves in a very similar way to para-aminohippuric acid, or PAH. PAH is freely filtered and actively secreted into the proximal convoluted tubule. So I'll continue drawing the efferent arteriole as it comes around right there. So again, PAH is actively secreted into the PCT. Ultimately, the majority of PAH that reaches the kidneys is excreted or lost in the urine. The idea here is that the secretion of drug X, or this step here, is a transport-mediated process. In other words, the secretion of drug X from the blood into the proximal convoluted tubule can become saturated if the plasma concentrations of drug X become so high that the transport protein's ability to secrete drug X is overwhelmed. So this process here can become saturated. On the other hand, the filtration process here cannot be saturated. This is because there are no proteins that are helping actively filter the substance from the glomerulus to the proximal convoluted tubule. So let me graph this out to show what's going on. The x-axis represents the plasma concentration of drug X, and the y-axis represents both filtration, so we'll do F for short, and the secretion of drug X. So filtration of drug X plus the secretion of drug X. As the plasma concentration of drug X increases, both filtration and secretion are able to increase. So filtration and secretion can both increase. So the slope of the line here is pretty steep at first. However, once the transport-mediated secretion process becomes saturated, it's no longer able to increase any additional secretion of drug X into the proximal convoluted tubule. So let's just say this becomes saturated and can no longer participate. This means that the only component of the system contributing to the net excretion, so here's excretion, so the only component of the system contributing to the excretion of drug X is filtration. So overall, the excretion of drug X will continue to increase, but it will be at a slower rate. And this is due to the saturation of the transport-mediated secretion process. So after we reach saturation, the slope will decrease like this. So again, saturation on this figure occurs right here. In summary, the excretion will continue to increase, as we can see, but the excretion rate will decrease. And this is illustrated by the slope of the figure. So the slope becomes less steep after saturation occurs. So that was a pretty complicated example, and if it was hard to follow, I encourage you to rewind the video and watch it again. The main idea here is that the secretion process can become saturated, and this reduces the nephron's ability to excrete different molecules. Okay, moving on. Fractional excretion is the amount excreted divided by the amount filtered. This equation is helpful in determining if the kidney is performing the normal reabsorption process properly. I'll draw out the nephron again to show you what I mean. Here is the glomerulus, the afferent arteriole, the efferent arteriole, proximal convoluted tubule, loop of Henle, and the collecting duct. This equation is comparing the excretion rate, which occurs right here, to the filtration rate, so F for filtration. Let's use sodium as an example and assume the kidney is filtering 100 milligrams of sodium. So filtering 100 milligrams of sodium. We know that some reabsorption, so reabsorption, and secretion normally occurs, and ultimately what remains is excreted. In this case, let's say the kidney is filtering 100 milligrams of sodium and excreting 3 milligrams of sodium. So excreting 3 milligrams of sodium. If we plug these numbers into our equation, we get 3 over 100, or 3%. This makes sense. The kidneys normally reabsorb most of the sodium, so we'd expect that the amount lost in the urine would be low. It's important to know that a fractional excretion of sodium greater than 2% may indicate intrinsic renal failure or post-renal azotemia. So a fractional excretion of sodium greater than 2 can indicate intrinsic renal failure or post-renal azotemia. In other words, the nephron normally reabsorbs the vast majority of sodium, so if it's being detected in the urine or being excreted, then we need to be concerned that the kidney is damaged and is not performing the normal function of reabsorption. Intrinsic renal failure and post-renal azotemia are specific pathology examples that are definitely more pertinent to pathology than physiology, but the idea of fractional excretion is important, and understanding it conceptually will be helpful when you encounter these topics in pathology. The last part of this section deals with acid-base. The focus here is simply to introduce the formulas. I'll be discussing these in much more detail in the section on acid-base. So there are 3 acid-base formulas that commonly show up on step 1. The first is the Henderson-Hasselbalch equation, which is the pH equals 6.1 plus the log of bicarbonate divided by 0.03 times the partial pressure of carbon dioxide. So pretty straightforward. This equation is simply used to calculate the pH of a buffer system. The major buffer system of the blood includes bicarbonate and carbon dioxide, so you can see that the equation has been formatted to calculate the pH of blood. Okay, the next equation is anion gap. This is calculated by measuring the difference between cations and anions. So sodium minus chloride and bicarbonate. This equation becomes important when trying to diagnose a metabolic acidosis. Finally, the Winter's formula is the partial pressure of carbon dioxide equals 1.5 times bicarbonate plus 8 plus or minus 2. This is useful when trying to diagnose a mixed metabolic acidosis and concomitant respiratory abnormality. Again, I'll discuss these formulas and their clinical relevance in much more detail when we get to the section on acid-base.